All right, this is Dr. Coucher. I'm going to be talking to you about inflammation and how we're going to provide nursing care to our adult clients, maternal newborn clients, or any pediatric clients. So, what is inflammation? It's a reaction to tissue injury or infection. And inflammation may or may not be the result of an infection. In fact, inflammatory responses related to infection only make up a very small percentage. Inflammation can be caused by trauma, surgical manipulation, extreme heat or cold, and caustic chemical agents. The idea of anti-inflammatory drugs is to reduce the fluid migration and the pain and lessen the loss of function so that we can improve our patient outcomes by increasing their ability to be more mobile with comfort. Chemical mediators that are released during the inflammatory process: histamines, kinins, and prostaglandins. Histamines are the first mediator in the inflammatory process. They dilate the arterioles and increase the capillary permeability. The kinins increase capillary permeability and cause the increase in the pain. Prostaglandins increase capillary permeability, increase vasoconstriction, also increase the pain with the fever, and relax the smooth muscle. There are cardinal signs of infection. Erythema, redness, that's the first phase of inflammation. Blood accumulates in the area of the tissue injury because of the release of the body's chemical mediators. The next thing is swelling. It's a second phase of inflammation. Plasma leaks into the interstitial tissue at the injury site. The kinins and histamine increase the capillary permeability at that point. Heat. This response can be caused by the increased blood accumulation and may result in the production of a fever. Pain can be caused by tissue swelling and the release of the chemical mediators. And then there's the loss of function because it gets compromised. I mean, when you have the edema that comes on, you got that accumulation of fluid at the tissue and injury site, and that causes increased pain, which decreases the mobility at the affected area. There are other various chemical mediators which are released during the inflammatory process. The prostaglandins, those are the chemical mediators that have been isolated from the exudate at the inflammatory site. Then we have the cyclooxygenase, or the COX enzyme. It's responsible for converting arachidonic acid into prostaglandins. This enzyme has two forms, COX-1 and COX-2. COX-1 protects the stomach lining and regulates blood platelets, and COX-2 triggers the inflammation and the pain. We're going to talk about COX-1 and COX-2 when we talk about some medications a little further on. There's the anti-inflammatory drug groups. These drugs have the analgesic, antipyretic, and anticoagulant effects. So you're looking at your non-steroidal anti-inflammatory drugs, your NSAIDs, corticosteroids, disease-modifying anti-hermetic drugs, and anti-gout drugs. NSAIDs inhibit the COX enzyme. So they inhibit the prostaglandin synthesis. They inhibit the biosynthesis of the prostaglandins. They exert an analgesic effect. They also have an antipyretic effect. They inhibit platelet aggregation. They mimic the effects of corticosteroids. Why do we use them? Reduce inflammation and pain. It's not recommended for fever or headaches, except for aspirin and ibuprofen. There are 7 groups of NSAIDs. The first generation NSAIDs, the salicylates, the parachlorobenzoic acids, the phenylactic acids, the propionic acid derivatives, the phenylmates, and the OXICAMS. And here's where we have our COX-2 coming in. These are our second generation NSAIDs. So aspirin, that's one of those. That's one of the first salicylates that we're gonna talk about. Its action has an anti-inflammatory, antiplatelet, antipyretic effect. relieves mild to moderate pain by inhibiting the COX enzyme. It's used for osteoarthritis and rheumatoid arthritis. We want to caution because you don't want to take other NSAIDs with it. Avoid during the third trimester of pregnancy. Do not give to children with flu or virus symptoms because of Reye syndrome. We just don't give aspirin to children at all really anymore. Side effects and adverse reactions: tinnitus, hearing loss, dizziness, confusion, drowsiness, GI distress, peptic ulcer, stomach bleeding, thrombocytopenia, leukopenia, agranulocytosis, and hepatotoxicity. There are some drug lab food interactions. With drugs, it can increase the bleeding when they're taking other anticoagulants. It can have a hypoglycemic effect when a patient is on oral antidiabetics. There's an increased gastric ulcer risk with glucocorticoids. They're going to have an increased PT, bleeding time, INR, uric acid, a decrease in their potassium, cholesterol, T3 and T4 levels. And there's also foods that contain it: prunes, raisins, licorice, I love licorice, and certain spices. Therapeutic level is 15 to 30 milligrams dilute with a toxic level of greater than 30. That's going to be a mild salicitis. If it's over 50, and I think that may be on one of my other slides, so I may be ahead of myself, then they're very toxic. Hypersensitivity or overdose may result in tinnitus, ringing in the ears, vertigo, bronchospasm, especially with asthmatics. And there again, that mild salicylism, that with that 30 milligrams, they're going to have a headache, confusion, sweating, drowsiness, thirst, nausea, and vomiting with diarrhea. If they have severe poisoning, it will result in convulsions and cardiovascular collapse and coma. So, your nursing process. This can be found on page 312 in your textbook. I always encourage you to look at these because it does contain a lot of vital information for you guys. So you want to look at your assessment. Make sure you obtain a thorough history on your patient. Look at your nursing diagnosis for them. Look at your planning. Pain will be reduced within 12 to 24 hours. Inflammation will be reduced within 1 week. So we need to monitor the serum salicylate levels. Again, these are I told you those levels already. Observe for signs of bleeding. When you think about signs of bleeding, what would you want to tell your patient? Let's see. If they start vomiting blood and it is frank blood, we want to know this. If they're starting to see black tarry stools, we need to know this. Patient teaching, report drowsiness, tinnitus, headaches, flushing, dizziness, GI symptoms, visual changes, and seizures. And we always want them to take these medications with plenty of food and plenty of fluids. And then, of course, we want to reevaluate the effectiveness and any side effects. All right, so perchlorobenzoic acid. Indocin, that is used for rheumatoid arthritis, gouty arthritis, and osteoarthritis. It's also considered a potent prostaglandin inhibitor. You have Salindac, which is a derivative that produces less severe adverse reactions. Telectin, that's the same as Salindac, but it is not highly protein bound, has also a short life. This group of NSAIDs may cause some sodium and water retention, so we need to be careful and cautious with our patients that have high blood pressure. Phenylactolic acid derivatives, diclofenac sodium or Voltaren, that's indicated for rheumatoid arthritis, osteoarthritis, ankylosing spondylitis. It does have an analgesic and an anti-inflammatory effect, but it does not have an antipyretic. Toradol, one of the greatest, inhibits the prostaglandin synthesis. It is recommended only for short-term management of pain. Voltaren does have it does come in a 1% topical gel, so it can be used in that way. It also is oral, has extended release. Side effects, adverse reactions are similar to those of other NSAIDs with far less detrimental reactions when they use that topical version. Toradol, that's a first injectable NSAID that we have. It is a great analgesic. And it has other anti-inflammatory, or greater than other anti-inflammatories is what I was trying to say. It usually is used for short-term management. It's often provided to patients in post-op recovery. It can be given in doses of 30 to 60 milligrams every 6 hours for adults. It can be done IV or could be done IM, either one. So it is one of those great ones. They do have it in a PO version as well. But again, it's going to be short term. We don't usually use Toradol for very long at all. Propionic acid derivatives. These are like aspirin, but stronger with less GI irritation. So you see, these are our naproxens, our ibuprofens. Ibuprofen adult PO 400 to 800 milligrams TID or QID. The maximum is 3,200 milligrams a day. Onset is 30 minutes to 1 hour. The peak is 2 to 4 hours and has a long duration of 6 to 8 hours. It reduces the inflammatory process, relieves pain, anti-inflammatory effect for arthritic conditions, and it is a fever reducer. We want to use extreme caution for patients with bleeding disorders, pregnancy, lactation, systemic lupus, erythematosus, asthma, peptic ulcer, anticoagulant therapy, renal or hepatic disease, and one not listed but of great benefit to know, patients who have had any gastric surgeries for weight loss, such as a bypass or a gastric sleeve, are cautioned against using any anti-inflammatories because of the risk of GI bleeds. Increased bleeding with oral anticoagulants such as warfarin, increased effects with phenytoin, sulfonamides, warfarin, decreased effect with aspirin, and may increase severe side effects of lithium. And there, of course, are some side effects. Gastric distress, so you need to take it with food, headache, dizziness, anorexia, diarrhea, edema, rash, and fluid retention. Some adverse reactions, hearing loss, tinnitus, bleeding, and life-threatening adverse reactions such as anemia, neutropenia, thrombocytopenia, nephrotoxicity, and anaphylaxis. So your nursing process can be found on page 314 in your textbook. Again, it's loaded with information. We want to do a good assessment of history, allergies, any current medical history, current medications. They have a risk for injury related to dizziness or activity intolerance. The planning, we want our inflammatory process to subside in 1 to 3 weeks. Interventions, patient teaching, do not take aspirin and acetaminophen with other NSAIDs. Avoid alcohol because of GI upset. Some herbal products may interact, and we'll talk about that on another slide. Inform dentists and surgeons before procedures if you're taking one. Avoid NSAIDs during pregnancy, congenital abnormalities, and labor bleeding can happen. Common side effects, nausea and vomiting, peripheral edema, GI upset, purpura, petechiae, and dizziness. Take with meals or snacks. All right, so phenamates, meclophenamate and mefenamate acid is Ponstel. These are potent NSAIDs used for acute and chronic arthritic conditions. Patients with a history of peptic ulcer should avoid taking this group of drugs. Side effects, gastric irritation, it's very common, edema, dizziness, tinnitus, and pruritus. OXICAMS, piroxicam, and meloxicam are indicated for long-term arthritic conditions. These can cause gastric problems like ulceration and epigastric distress, but they're well tolerated. You'll have full clinical response in 1 to 2 weeks. They should not be taken with aspirin or other NSAIDs. They do tend to have fewer side effects, but gastric irritation is a very common complaint, especially if they take it without food. These meds may increase sodium and water retention, so again, we have to look at our patients with high blood pressure or cardiovascular disease. Caution patients against drinking alcohol because, again, this can increase the risk of GI irritation. Okay, so this is where we're going to talk about some natural substances that patients might take. This is a special note. Dong quai, feverfew, garlic, ginger, ginkgo. These all may cause bleeding when taken with non-steroidal anti-inflammatory drugs. Selective COX-2 inhibitors. These are the second generation of NSAIDs, which have become available in the past several years to decrease inflammation and pain. There is some noted decreased production of the protection of the stomach lining, and clotting time is also decreased. With the clotting time decrease, this may be a benefit to our patients with cardiovascular or coronary artery disease. Celebrex is a drug of choice for patients with severe arthritic conditions who need that high dose of an anti-inflammatory. These selectively inhibit COX-2 enzyme without inhibiting COX-1. It decrease inflammation and pain. Nabutamol or Relafin, are not considered a true COX-2 inhibitor, although it does inhibit the COX-2 more than the COX-1. So it's just a very similar agent. This can be taken PO 100, and we're talking about Celebrex now. 100 to 200 milligrams QD or BID, a maximum dose of 800 milligrams a day. There is a special note here. Some gastric weight loss physicians will allow patients to take this medication in its lowest dose, but it must be taken with food. Caution is to avoid during third trimester of pregnancy. Patients may experience headache, dizziness, sinusitis, abdominal pain, nausea, flatulence, diarrhea, and rash. Adverse peripheral edema, bleeding, hypertension, and stroke. NSAIDs in older adults, there is a greater incidence of GI distress and ulceration. Reduce the dose, but it will decrease the risk of any side effects for them. Corticosteroids, we're not going to go over these quite a bit, okay? We're just going to kind of hit on them for a second. These are only mentioned because they're used in flare-ups, but we're not going to cover it in great depth. Prednisone, prednisolone, dexamethasone. These do control inflammation by suppressing or preventing components of the inflammatory process at the injured site. Not the drug of choice for arthritis because of their numerous side effects. Frequently used to control the arthritic flare-ups, and you want to taper off over 5 to 10 days. Disease-modifying anti-rheumatic drugs, DMARDs. And I will be calling these DMARDs from now on because it's so much easier to say. These drugs may be prescribed when NSAIDs do not control immune-mediated arthritic disease sufficiently. We're going to talk about immunosuppressant agents, immunomodulators, and antimalarials. The DMARDs used to treat refractory rheumatoid arthritis, psoriatic arthritis, severe psoriasis, ankylosing spondylitis, Crohn's disease, and ulcerative colitis. Imurin is one of the drugs, Cytoxan, and methotrexate. It's often used to suppress cancer growth. We know that we also give methotrexate to pregnant women who are, an imminent pregnancy loss is coming. If they have fetal death or embryo death, we'll give it to them. But these can also be used to suppress the inflammatory process of RA when other treatments are failing. So the DMARDs are used for the severe RA by disrupting the inflammatory process and delaying the disease progression. We got two forms with it here. We have the interleukin-1, IL-1, which is a receptor antagonist, and a tumor necrosis factor, TNF blocker. There are two different groups of drugs in this classification. Anakinra, and I probably said that wrong, blocks the activity of IL-1 by inhibiting it from binding to interleukin receptors located in the cartilage and bone. It's usually administered sub-Q and it peaks in 3 to 7 hours. Tumor necrosis factor blockers, TNF blockers, their action is to bind to TNF and block it from attaching to the TNF receptors on the synovial cell surfaces. Enbrel was one of the first TNF blockers developed. Its half-life ranges, and it's amazing, from 72 to 132 hours. Signs and symptoms of RA are suppressed rapidly, but will reappear if the drug is discontinued. Of special note, IL-1 receptor antagonist and TNF blockers do predispose your patient to severe infections. They are contraindicated in active infection and should be discontinued when the infection occurs. Immunomodulators are usually very, very expensive also. And we're going to talk about Remicade on the next slide. We talk about Remicade because we're using it as part of the nursing process. One of these in your textbook, page 316. You want to look at your history, baseline renal and LFTs, nursing diagnoses, the planning. Pain's going to be reduced in 12 to 24 hours. Inflammation will be reduced within the 12 to 24 hours. We need to make sure we obtain a negative TB skin test before starting the drug, monitoring for infection, monitor lab values, and administer IV over 2 hours through 1.2 micron or less filter. We're going to teach our patients to keep appointments, avoid live vaccines, report dizziness, chills, depression, dyspnea, severe infections, seizures, fatigue or rash, and report infections immediately. And then we want to evaluate the response to the DMARD. Antimalarials. This is also a DMARD. May be used to treat rheumatoid arthritis when other methods of treatment fail. The action's really unclear. They don't know why. The effect may take 4 to 12 weeks to become really apparent. Antimalarials are usually used in combination with NSAIDs in patients whose arthritis is not under control. Okay, so the pathophysiology of gout. It is an inflammatory disease of the joints, tendons, and other tissues. It's very painful. Usually occurs in the great toe. It is characterized by uric acid metabolism disorder and a defect in the purine metabolism, which leads to the uric acid accumulation. So we want our patients to avoid purine-containing foods, organ meats, sardines, salmon, gravy, herring, liver, meat soups, and alcohol, especially beer. Colchicine, I just butchered the name, I'm really sorry, is the anti-inflammatory gout drug. It inhibits the migration of leukocytes to the inflamed site. It reduces inflammation in gout, but not other disorders. It does have some side effects, GI distress. With high doses, they're going to have nausea, vomiting, diarrhea, and abdominal pain. We want them to take it with food to avoid GI distress, and it is contraindicated for severe renal, cardiac, or any GI problems. Allopurinol, that's a uric acid inhibitor. Its action, it decreases the production of uric acid, inhibits the final steps of the uric acid biosynthesis. It is a prophylactic to prevent gout attacks. Side effects, anorexia, nausea and vomiting, diarrhea, stomatitis, dizziness, headache, rash, metallic taste, edema, erectile dysfunction, diaphoresis, and peripheral neuropathy. Our nursing interventions, we're going to monitor their CBC, liver enzymes, and renal function. We want to make sure our patients get yearly eye exams for visual changes. Advise the patient to avoid alcohol, caffeine, thiazide diuretics that increase uric acid levels, and advise the patient to increase their fluid intake to increase uric acid excretion. So our nursing process found on page 319 and 320 in your textbook. We want to get a history. We need to get serum uric acid levels. We need to look at look at their labs. How about the nursing diagnosis? They might have impaired tissue integrity, definitely acute pain. The planning, pain will be absent or controlled without side effects. Nursing interventions, report GI symptoms, record I&O, monitor labs, and we need to make sure we do patient teaching and reevaluate. Uricosurics, their action, these are still anti-gout drugs. Increase uric acid excretion by blocking reabsorption of the uric acid. This is used for chronic gout, not acute attacks. Benamine and Turine, the side effects are gastric irritation. Most all of these have gastric irritation if you haven't figured that out just yet. Patient needs to take it with food. Nursing interventions, use caution when giving with other highly protein-bound drugs, and the patient should increase their fluid intake to increase their uric acid excretion. Okay, that's the end of your lecture. You will have a discussion board to follow.